Welcome to Module 1 of the 5-minute Clinical Consultation Masterclass for OET Medicine. In this opening segment, we are evaluating the strict chronological reality of this examination, the absolute limits of your timeline. The single most common failure pattern among highly competent international medical graduates is not a lack of clinical competence, nor is it a deficiency in conversational English. It is a structural time failure. Look at the scorecard layout on your screen. This profile represents hundreds of candidates who enter the exam room, deliver flawless medical grammar, establish deep empathy, and yet consistently walk away with a score of 340, just 10 points short of GMC registration. They fail because they treat the exam card like a comprehensive, open-ended hospital admission. They let their defensive medical instincts take over. They spend 4 minutes performing exhaustive data gathering, leaving less than 60 seconds to discuss patient management. In the eyes of the examiner, an incomplete consultation card is an automatic structural failure. Let us examine exactly how the criteria penalize this approach. Let's look closely at Clinical Communication Criterion C3, providing structure. Examiners are explicitly trained to look for 3 chronological milestones during your 5-minute interaction. First, they evaluate your sequencing. Are you moving logically from identification to management, or are you bouncing back and forth between history taking and treatment advice? If a candidate asks about smoking history while explaining a prescription, the clinical logic collapses instantly. You must isolate your diagnostic phase entirely from your management phase. Second, they grade your signposting. Are you explicitly telling the patient when and why you are shifting the focus of the consultation? A passing candidate never leaves a patient wondering why the topic changed. They use explicit framing markers, such as, "Now that I understand your immediate symptoms, I need to move on and ask a few targeted questions about your medical background." This keeps the examiner aligned with your structural map. And third, look at the final threshold, time management. You are being actively marked on your ability to control the velocity of the patient. If a patient is talkative, anxious, or uncooperative, and you allow these structural liabilities to drag the diagnostic phase past the 3-minute mark, the examiner cannot award a passing grade for structure. You have lost control of the consultation timeline, and the scorecard will reflect that loss instantly. Let's take a look at how to prevent this. To ensure a predictable pass, you must replace conversational guesswork with a fixed chronological blueprint. Look at the 5-minute clinical consultation timeline on your display. This is your operational blueprint and hard ceiling. You have exactly 5 minutes. Your opening 60 seconds are strictly reserved for validating the patient's state, confirming identity, and establishing clinical control over the agenda. You must establish the boundaries of the conversation early by saying, "My goal today is to look at your current symptoms and together build a clear management plan." This anchors stage 1, clinical control. From minute 1 to minute 3, you execute stage 2, targeted exclusion. You are not asking open-ended lifestyle questions. You are gathering the specific diagnostic data required to safely unlock the treatment options on your card. If the card doesn't require a dietary history, you do not ask it. The 3-minute mark is your hard ceiling. Regardless of what information you have or have not gathered, you must terminate data collection, execute a structural signpost, and bridge directly into stage 3, collaborative management. You require a full 2 minutes to walk the patient through their options, check their understanding using active loopback questions, and secure their agreement before the final buzzer sounds. Management is where the majority of your marks reside. If you enter this phase with only 45 seconds remaining, it is mathematically impossible to demonstrate collaboration. To see the precise moment a passing grade slips away, we will project a suboptimal consultation transcript directly over this timeline. Let's look straight at the data. Stepping directly into the testing environment, watch how this structural flaw manifests during a live interaction. On your display is a verbatim performance excerpt from an acute pain roleplay card. The clinical scenario is highly pressurized. The patient presents with acute, localized abdominal pain and is aggressively demanding a fast fix so they can leave for a vital merger meeting. This is a classic conflict scenario designed to disrupt your pacing. Observe the dialogue stream analysis on your left. Let me be clear. This candidate's English is advanced. It is grammatically flawless, and it is delivered with total professional confidence. If this were a simple language test, they would pass easily. Yet at exactly 1 minute and 45 seconds into the consultation, you will observe the precise moment the timeline fractures, and why linguistic proficiency alone cannot save a structurally compromised room. Look at the candidate's first line of dialogue. They attempt to validate the patient by saying, "I completely understand that the abdominal discomfort is severe, Mr. Davis, and I am going to address your pain shortly." This is a technically correct linguistic phrase taught by generic textbooks. It demonstrates empathy on paper. But notice the catastrophic pivot that immediately follows. However, to ensure clinical safety, I must first ask, have you noticed any changes in your bowel habits or any recent unintended weight loss? Look at the consultation clock on your display. 2 minutes and 15 seconds have already evaporated inside this passive information gathering loop. Because their defensive clinical instincts are screaming for a surgical obstruction, they continue to execute historical tracking. They are prioritizing a medical checklist over the structural reality of a timed room. They are acting as a doctor on an open-ended ward round, rather than a candidate with strict chronological limits, and in doing so, they are actively bleeding marks under Criterion C3. Now, look at the highlighted response from the patient at the 3-minute mark. The patient pushes back aggressively. "Look, doctor, I don't have time for a full checkup. Can you please just inject the morphine so I can get out of here?" This is not a random outburst. This is the deliberate curveball written directly onto the patient's roleplay card. The examiner is explicitly testing whether you possess the structural command to absorb resistance, terminate your data gathering, and control the timeline. A passing candidate recognizes that at 3 minutes, the diagnostic runway has ended. You must move on. But watch how archetype A responds in the red bordered section. They double down on medical defensiveness. "Yes, I hear you, but before administering strong opioids, it is absolutely essential that I review your complete history of past surgical interventions." Look at the timeline crash metric on your right. By indulging this historical tracking loop, the clock ticks to 3 minutes and 22 seconds. The clinical runway is completely gone, the timeline has collapsed, and they have just chosen to lose the exam. Look at the criteria metric stream on your console. The candidate's linguistic resource remains anchored at a high passing tier. Their vocabulary remains immaculate. But notice what has happened to Criterion C3, providing structure. It has dropped directly into the critical failure zone. By answering the patient's time anxiety with an open-ended demand for more background history, the candidate completely surrenders structural control. Look at the timeline crash metric, 3 minutes and 22 seconds. Valuable time has evaporated, and the candidate is still stuck in historical data collection. They have left themselves barely 1.5 minutes to execute the entire collaborative management plan, discuss opioid contraindications, and secure the patient's informed compliance. It is mathematically impossible. As the final buzzer sounds at 5 minutes, this card will remain profoundly incomplete. A devastating fail at 340, driven entirely by structural mismanagement. We have diagnosed the pathology of a failed consultation. Now we implement the cure. Medical professionals are uniquely trained to listen actively. In a real-world clinic, this is an asset. But in a highly constrained 5-minute OET assessment, passive historical tracking is a fatal liability. If you let the patient drive the narrative, you will run out of time. To guarantee a passing grade under Criterion C3, you must abandon conversational improvisation and adopt a rigid, unyielding structural framework. Look at the core correction framework on your display. This is exactly how an examiner tracks your performance structure. Stage 1 is clinical control. You have exactly 1 minute. Your objective here is not small talk, it is to validate the patient, confirm identity, and set an explicit agenda. Stage 2 is targeted exclusion. From minute 1 to minute 3, you are not taking a sprawling medical history. You are extracting only the highly specific data points required to safely unlock the management phase. You are actively filtering out irrelevant patient narratives, and then you reach the 3-minute threshold, the highlighted boundary on your screen. This is the single most critical moment of your exam. At exactly 3 minutes, regardless of what the patient is saying, you must execute a structural pivot, the exact mechanism required to safely launch stage 3, collaborative management. The question is, how do you track this during a live, highly pressurized encounter? You do it before the clock even begins. When the examiner hands you the roleplay card, your adrenaline will spike. You are given 3 minutes of silent preparation time. Do not waste this time merely memorizing the patient's name or reading the card like a novel. You must dissect it as a structural map. Look at the annotated card on your display. Now, in the real testing room, the OET writers will frequently mix these tasks up to break your rhythm. But during your prep time, your job remains the same. Locate the first definitive management task on that sheet and draw a physical horizontal line directly above it. Separate your diagnostic phase from your management phase before the clock even begins. That physical line acts as your cognitive anchor. As you can see on the timeline sync grid on your right, when the clock hits 2 minutes and 42 seconds, you should be clearing your final history check. Even when the patient is pushing back, that boundary gives you the psychological permission to interrupt and pivot. If you allow the patient to keep you above that line past the 3-minute mark, you are surrendering structural control. You must use a clinical bridge to force the conversation downward. Recall our failing candidate from the previous segment. At the 3-minute threshold, the patient hits them with the exact resistance loop displayed on your right. Look, doctor, I don't have time for a full checkup. Can you please just inject the morphine so I can get out of here? A weak candidate reacts defensively. They apologize, or they say, I just need to ask a few more questions. This destroys your authority and agitates the patient further. Instead of falling into that defensive loop, a passing candidate deploys a structural bridge. Look at the 3-step structural bridge on your screen. Step 1 absorbs the resistance cleanly without entering a gridlocked argumentative trap. Step 2 validates the baseline urgency of their discomfort to lock in rapport. The 3rd step is the immediate execution of this highlighted verbatim script. Mr. Davis, I hear you, and getting this pain under control is my absolute priority. To safely authorize that medication, we need to pivot straight to our care plan so we can get you comfortable and moving forward. Notice the architecture of that exact phrase. There are no apologies, there is no defensive posture. It is polite, it is profoundly empathetic, but it is structurally immovable. As you can see below, stage 3 entry is instantly secured, leaving you a full 2 minutes to run your timeline cleanly. Mastering this structural pivot requires precise mechanical repetition. Under exam conditions, your internal clock will distort. 5 minutes will feel like 60 seconds. To help you pinpoint exactly where your mechanics are failing, look at the timeline integrity audit engine on your display. If you are consistently falling into the open-ended loop or issuing defensive apologies, your timeline risk profile will cross into the danger zone and your room will collapse under exam pressure. You can run this structural calculation immediately using the interactive tool below this video frame. However, Diagnosing your baseline layout error is only half the battle. You must install the precise clinical vocabulary to fix it. If you struggle to anchor your presence early, Module 2, First Minute Control, establishes your professional authority with a predictable clinical opening sequence. If you lack the exact phrasing to handle an anxious, talkative, or hostile patient without sounding dismissive, Module 3, Patient Redirection, equips you with strict verbatim scripts to safely neutralize talking loops. And if you find yourself rushing as the clock runs out, Module 4, Shared Management, delivers the structured communication loops required to close the encounter cleanly before the final buzzer. We are not just memorizing vocabulary, we are installing a strict chronological framework to eliminate timeline collapse. Take the audit, lock in your structural framework, and I will see you in Module 2.